Hello everyone, my name is Sydney Kolosky and I'm a fourth-year pharmacy student at the University of Connecticut School of Pharmacy, and I worked in conjunction with Dr. Jennifer Gerardo, clinical professor, on this project. And today I'm going to walk you through a summary of a blog post I wrote on an important topic in pediatric infectious diseases, which is neonatal late-onset sepsis. The blog post I'll be discussing is titled Neonatal Late-Onset Sepsis, Antibiotic Trends and Future Directions in Antimicrobial Stewardship, which I wrote for the Pediatric Infectious Diseases and Immunization Updates series, and you can find it on the UConn School of Pharmacy website. As previously mentioned, the focus of this blog post, which you can find linked in the description below, is neonatal late-onset sepsis. It is a major cause of morbidity and mortality in preterm infants and continues to drive high antibiotic use in this population. This review specifically describes the current United States epidemiology, causative pathogens, and antibiotic use trends to improve understanding and treatment of this disease state. Some of the key takeaways from this blog post are that data from the 2022 study using the Vermont-Oxford network data describes late-onset sepsis as being primarily driven by gram-positive organisms, accounting for roughly 63% of isolates studied. Specifically, the gram-positive isolates found include coagulase-negative staphylococci, Staphylococcus aureus, Enterococcus species, and group B streptococcus. To understand the treatment of late-onset sepsis, the 2025 study by Coggins and colleagues looks specifically at current antibiotic use trends throughout the United States, and it found vancomycin to be the most common individual component in the antibiotic regimens studied. However, the overall use of vancomycin-containing regimens remarkably declined from 59% of all courses in 2009 to 36% in 2023. The decline of vancomycin occurred at the same time there were increases of prescriptions for beta-lactams with strong antistaphylococcal coverage, including nafcillin and oxacillin, which went from 7% to 18%, piperacillin tazobactam, which went from 3% to 9%, and cefepime, which went from 2% to 12%. Notably, the 2022 study by Nationwide Children's Hospital concluded nafcillin is a safe alternative to vancomycin for empiric therapy in neonates specifically who were not colonized by MRSA, as there was no difference in mortality. Looking at antibiotic treatment durations in the United States, recent data from Spire and colleagues found that the median antibiotic treatment duration for late-onset sepsis was 4 days for a culture-negative evaluation and 12 days for a culture-positive episode. Although there are not any consensus guidelines in the United States for antibiotic treatment durations, the National Institute for Health and Care Excellence in the United Kingdom recommends that antibiotics be continued for 7 days if the neonate has a positive blood culture, or discontinued before 48 hours if the neonate has a negative blood culture and thought to no longer have an infectious cause. These longer durations found in the data from Spire presents an area of opportunity for antimicrobial stewardship programs to focus on in the future. So what does this mean in practice for pharmacists and other healthcare providers? Well, this review presents two areas for intervention. First, pharmacists and other healthcare providers can utilize local susceptibility data depicted in antibiograms to ensure empiric therapy options are being chosen that cover isolates seen in their own units and that also act as the narrowest effective agents expected to cover the organisms of concern. Secondly, the longer duration of treatment in both culture-negative and culture-positive groups emphasize the need for targets to be set by antimicrobial stewardship programs to help ensure prompt discontinuation of antibiotics when treatment is no longer required, in order to minimize antibiotic exposure and resistance development in this population. The current antibiotic trends discussed in this review can help play into considerations for empiric therapy options. For example, for patients with no history of MRSA colonization or infection, they can be treated with nafcillin or oxacillin, plus either gentamicin, an extended-spectrum cephalosporin, amikacin, or carbapenem. On the other hand, for patients who are colonized with MRSA or have a history of a MRSA infection, they can substitute vancomycin in place of nafcillin or oxacillin to provide MRSA coverage in their treatment plan. All in all, by understanding this update, pharmacists, along with other healthcare providers and trainees, can better support evidence-based care for neonatal late-onset sepsis. Here are the references we used for this presentation. And to learn more, please check out the full blog post linked in the description below. If you found this summary helpful, please like, share, and subscribe for more updates in the pediatric infectious diseases and immunization space. Thanks for watching!